Hello, everyone. Today, I'd like to share with you all a framework for helping trainees manage uncertainty. These are the relevant clinician educator competencies. Why do trainees struggle with uncertainty differently than more experienced clinicians? This is because they are earlier in their knowledge. They often perceive uncertainty as a stressor or a threat that is intended to be eliminated as opposed to something that is innate in clinical medicine. And they often feel like uncertainty is the same as incompetence. Early on in medical education, they're taught to use logical causal pathways to arrive at singular answers on standardized tests. And during clinical case conferences, it is often framed as, a diagnosis is obtained after a singular test is ordered. So uncertainty manifests in a number of different ways. It is very rare for a trainee to outright say, I'm experiencing uncertainty. Instead, they'll say things like, I'm worried. They'll express hesitation about a particular situation, but won't be able to articulate what it is exactly that's bothering them or that worries them. They may overorder tests or interventions unnecessarily in an attempt to cover all of their bases and eliminate uncertainty entirely, or they'll simply avoid uncertainty. And this may manifest as not being able to commit to a plan, or they might actually be overconfident and overlook a lot of the nuance and uncertainty in a situation. Now, experienced clinicians recognize uncertainty through various cues and work through it deliberately. So it's our job to help them navigate uncertainty, as opposed to simply labeling a trainee as good or bad with uncertainty. So the first step is to name it and organize it. Where does the uncertainty stem from? Does it stem from diagnostic uncertainty, something about the treatment, prognostic uncertainty, or perhaps a systems or logisticals level issue? The second thing to do is to figure out what kind of uncertainty is it. And this falls into one of two buckets. The first is called epistemic or informational uncertainty, where by obtaining more data, we can actually reduce the amount of uncertainty in the situation. The other type is called aleatoric or intrinsic, where outcomes are actually inherently unpredictable no matter how much data is obtained. And the distinction helps us guide what to do next. Do we simply look something up if it's a case of informational uncertainty? Do we order another test? Or if it's intrinsic to the situation, do we actually plan for risk? So helping trainees identify where it comes from and what type of uncertainty then helps them to figure out what to do next. So experienced clinicians navigate uncertainty with two core processes when it comes to the intrinsic uncertainty that's irreducible. The first thing we often do is forward plan. And in this situation, we utilize if-then thinking. We simulate how something might evolve based on our knowledge and prior experience and think of contingency plans to put in place. So, for example, if this happens, then we'll respond in this way. The second thing we often do is to utilize monitoring. And this means integrating signals from a variety of sources, whether they're vitals, labs, the patient's reported history, our own internal sense of concern, or cues that we're receiving from other people, such as the bedside nurse or the respiratory therapist. We integrate all of these things into our decision making to tell us whether we're on or off track. And so by highlighting or signposting this to learners, we allow them to see that these are actually concrete skills that they can learn to navigate uncertainty. So for example, there's the classic case of what to do in the context of hyponatremia. Do we give fluids? Do we restrict fluids? And so a way to model the uncertainty of this type of situation could be to say, well, if the sodium decreases after giving a small bolus of fluids, then we'll stop and we'll actually fluid restrict them. And for monitoring, we'll recheck the sodium after the fluids are given, and maybe we'll repeat the test every 4 hours until it gets to a safer range. So normally, trainees find this situation challenging because they're unsure of whether a patient's sodium might overcorrect or worsen with fluids. They'll want more diagnostics, and they can be paralyzed by the uncertainty. But by modeling the forward planning and the monitoring skills, we can help them navigate through the situation appropriately. Now, the temptation can be, as a supervising clinician, to remove uncertainty by giving learners the answer. But in many circumstances, it's actually better to stay with the uncertainty and teach the learners how to make it safe. By doing this, we model confidence with uncertainty as opposed to confidence instead of uncertainty. So in summary, we can teach trainees how to navigate and manage uncertainty by giving them a structured approach instead of eliminating it. This starts with naming the source first and foremost, whether it's diagnostic, treatment-related, prognostic, or logistical. Then to determine whether it's a lack of information or if this uncertainty is simply intrinsic to the process. If it is intrinsic to it, then we can model to them the skills of forward planning and monitoring. These are the references for this talk, and thank you for your time.